Hi everyone, my name is Rachel, and today I am going to talk about the health belief model and how it can be used as a theory to build an intervention in HIV PrEP. To begin, the health belief model derives from psychological and behavioral theory with the foundation that there are two components of the health-related behavior. And those are one, the desire to avoid the illness, and two, that the belief that a specific health action will prevent or cure the illness. Ultimately, an individual's course of action often depends on the person's perceptions of the benefits and barriers related to that health behavior. And within the health belief model, there are 6 different constructs. And that is from the article Behavioral Change Models. The health belief model can provide a useful framework for understanding individual factors and decisional processes that could influence the initial engagement in PrEP use. This model describes a person's health behavior, and in this case, it'll be if they will engage in PrEP care or not. So to begin with our population, we have chose Hispanic and Latino men that have sex with other men living in Miami-Dade County, Florida. Within Miami-Dade County, men who have sex with men are 55% of the affected number of people with HIV, and Hispanic and Latino are 48%. To begin the health belief model, we will look at the modifying factors, and those are demographic variables, which are age, gender, socioeconomic status, or education, and the psychological characteristics, which is personality and sexual orientation. The first construct of the health belief model is perceived susceptibility. This is the perceived risk of acquiring an HIV infection that the individual feels. This refers to a person's subjective perception of the risk of acquiring HIV. There is a wide variation in a person's feelings of personal vulnerability to an illness or a disease. So essentially we're going to look at to see how much they feel that they are at risk, and that could be used to understand a way to get them to use PrEP. The next construct is perceived severity. This we will look at for the individual their perception of how bad it would be if they were to contract an HIV infection and if they had to live with it. And according to the article Health Belief Model, this refers to a person's feelings on the seriousness of contracting the illness or the disease, and there's a wide variation in a person's feelings of severity, and often a person considers the medical consequences and the social consequences, such as family, social relationships, when evaluating the severity of that infection. And then next is we'll look at the evaluation of the behavior, and that'll be perceived benefits. And this will be understanding how they feel about the benefits of using PrEP. And according to the article Health Belief Model, this refers to a person's perception of the effectiveness of various actions available to reduce the threat of the disease. The course of action a person takes in preventing it, or they rely on the consideration and evaluation of both perception, susceptibility, and the benefit, such that the person would accept the recommended health action if it was perceived as beneficial. So we will want them to really look at how they could see the benefits of taking PrEP and how it would affect their life. Next is perceived barriers. And these barriers, we would look at what would be present in our population that would prevent them from getting PrEP. This could be lack of insurance, lack of money to pay for it, social consequences such as the stigma behind if people were to find out they were taking PrEP. That could be a barrier to get them to want to take it. And that needs to be analyzed when developing this intervention. And then next is the cue to action. So according to the article Health Belief Model, this is the stimulus needed to trigger the decision-making process to accept a recommended health action. So these cues can either be internal or external, and for our intervention, it would be more external, such as advice from others, and just ways to get people to remind them to take PrEP would be kind of the route that we are going to go. The next construct is self-efficacy. This is how confident someone is about taking PrEP in the eyes of their peers, and this would be, again, linked to the stigma concerns. And according to the article Health Belief Model, this refers to the level of a person's confidence in his or her ability to successfully perform the behavior. This construct was added to the model most recently in mid-1980 and is a construct in many behavioral theories as it directly relates to whether a person performs a desired behavior. So these last two constructs lead to the likelihood of the behavior. And overall, we really just have to evaluate their desire to use PrEP and understand ways to get them to take it. So I looked at an article by Pinto, and it looked at barriers that were often in the way of people using PrEP. And they analyzed the case study and found that barriers such as funding and or insurance was a big one. The lack of funding is the most consistently cited system-level barrier, including limited health budgets to sustain PrEP programs and lack of insurance coverage. And then there was a barrier for Black and Latino men, and this included the decreased access to private health insurance and more access through public clinics, as well as frequently endorsed stigma-related concerns about PrEP. So the purpose of this case study was to review the identifying barriers to PrEP implementation and interventions to improve it. And the study, they used the health belief model to figure out, ways to build successful interventions. And there are pros and cons both to this theory. And the pros of the health belief model, they are used to change the behavior. Educating about PrEP can result in people acknowledging their current behaviors and want them to change in the future for better health outcome, and it allows them to take control of their health and allows them to control their behaviors and ways to reduce an HIV infection. And there are also cons that come with this theory. If people are not willing to make the changes, this will be kind of harder to work with. If they are not willing to break habits, focus on behaviors of a health outcome, but doesn't take into consideration what that people make their choices based off their social situation. So this can again is a great to get them to change that behavior, but in the end they really want to. If they're in the end, they're really going to have to change that behavior. We ultimately really want people to change their behaviors, and this will result them in taking in PrEP to protect themselves. And this is kind of a route that we will take to build our intervention when looking at our target population in Miami-Dade County, Florida, and ways to get them to use PrEP. Thank you for listening.